Hello everyone, this presentation will be on the approach to a sick child. The slides are made available by the Indian Academy of Pediatrics as a part of the IAP UG teaching module 2015-16. Before getting into the topic as such, there are a few things which I would like to highlight. The Indian Academy of Pediatrics, previously in conjunction with the American Heart Association and now on its own as a part of the ALS and BLS subchapters, conduct these programs what we call as PALS, that is Pediatric Advanced Life Support. In general, these workshops last for 3 days, wherein the first day training goes towards BLS, that is basic life support, and the remaining 2 days goes into advanced life support. Now, I think at max my presentation will be quite short, and one thing which you all should understand is this presentation cannot replace a face-to-face training of PALS. Secondly, the target audience for PALS is generally towards healthcare workers who work day-to-day in pediatrics and for pediatric residents. But the target audience for this presentation is towards the undergraduate medical student who often does not have much exposure towards identifying a sick child. Now, in our times currently, where there is undoubtedly an acute shortage of healthcare workers, it is imperative that whether a pediatric specialist or not, a healthcare worker, if not the general public, should be able to identify who is a sick child and what help a child who is sick requires. In that context, I would also like to share one web link, iapalsbls.org, where the entire full guidelines is available. I'll not be telling the entire guidelines in this presentation because it is undoubtedly quite time consuming, but rather what I will be doing is just giving an overview towards approach to a sick child and towards the basic management and the assessment. I am again reiterating this, it cannot replace a full PALS session, but it is more of a sensitization and giving awareness towards the undergraduate medical student on what to expect. On that note, we come to the objectives of it, and at the end of this presentation, the viewer, that is you, will be able to understand who is a sick child, how to recognize and how to initiate management. I'll not be going into the full details of management, but rather how to initiate management. So the key to any emergency in the ER is always on early recognition of a critical illness, and prompt treatment can always save lives. So when I say initial assessment, the first thing what we need to see is whether the child is sick or not. Now, if you go merely by parental history, based on parental history, any parent who brings their child to the hospital will bring their child either for a routine vaccination or because they feel that their child is ill or sick in some way. Routine vaccination is undoubtedly not an illness, but any other disease, they will perceive their child to be sick or ill or having some complaint. When I say sick here, I don't mean having a common complaint, but rather sick in the sense it is life-threatening. So whenever I use the word sick child in this presentation, I mean the child having a life-threatening complaint. So with that, to define a sick child as such, any critical illness or a sickness in a clinical state that may result in respiratory or cardiac arrest or severe neurological complication if not treated properly. So if you do generally see here, based on this definition, the three systems upon which we are focusing are the cardiovascular system, the respiratory system, and the central nervous system. So based on these three systems, we are classifying a child as sick child if there is going to be a cardiovascular arrest, a respiratory arrest, or a severe neurological complication. So we'll first come to what we call as a cardiopulmonary assessment. A cardiopulmonary assessment is what we assess the child as soon as the child walks in. The assessment begins from the waiting room onwards. So we have in this what we call as the initial impression, the primary assessment, followed by a secondary assessment and diagnostic test. In a routine OPD, the general procedure in most hospitals or clinics is, let's assume that this is the clinic. Towards the back, what we have here is the consultation room. This is the entry, this is the reception, this is the waiting area, and say this is the pharmacy. Okay, what I'm going to draw in red now is the parent bringing the child inside. They will register at the reception, take their seat, wait for their turn to come, consult the doctor. Based on consultation, if any investigations is needed, they will give the investigations, collect the reports, show the consult once more, go to the pharmacy, buy the prescription, and then leave. This is a routine office practice what happens. But in a casualty setting, if we do consider a casualty setting, we'll just for simplicity's sake assume an 8-bed casualty and assume that a child is brought instantly and is kept on, say, bed number 1. He is attended by a team where there is an initial impression which is given, followed by a primary assessment, then a secondary assessment and a diagnostic test. Now, if you notice the difference between the first and the second step, in an emergency setting, they are brought directly and is directly seen by the healthcare professional or the doctor and is not going through the intermediary. Now, the significance of this you will understand shortly. Now, when I say initial assessment, it is something which is hands-free. And by hands-free, I mean it is just like visual inspection. So, we are considering a triangle here. What you see here, consciousness, breathing and color. Remember it as CBC for now. I'll come to all of this in much more detail shortly. You'll understand it in detail. So that is the first initial assessment where we check for the consciousness of the child, the breathing of the child and the color of the child. Each of these points we will discuss in detail in subsequent slides. For now, just recollect the casualty setting where we said that the child is brought to bed number 1. So the initial impression is to check for the consciousness of the child, to check for the breathing of the child and to check for the color of the child. Then the primary assessment is in simple terms an A, B, C, D and E. So because there are 5 components, in the first one we drew a triangle. So here we will draw a pentagon. A, B, C, D and E. A stands for airway, B stands for breathing, C stands for circulation, D stands for disability and E stands for exposure. Again, each of these we will discuss in detail. Subsequently, a secondary assessment where we look for focused history and thorough physical examination. Focused history has some points which has to be assessed in detail, followed by a thorough physical examination. Now, when I say focused history, our general pediatric case sheet format has chief complaints followed by a history of presenting illness, followed by a past history, birth history, developmental history, antenatal history, natal history, postnatal history, dietary history in detail. In an emergency, we have to prioritize out of these which we consider as important and which we consider as focused. Stabilize a child and then take a full regular detailed pediatric history, followed by a thorough physical examination. History and examination alone gives maximum clues towards this child. I'll just give a simple example to highlight what I'm trying to say. In the same scenario, assuming that a child is brought unresponsive to a casualty setting and the child is not identified and is brought by bystanders, at that time a focused history would rather be relevant of how, in what circumstances was the child received, what first aid was given, how the child was brought, whether any event happened along the way such as having seizures or breathlessness or gasping. That would be a focused history as opposed to a full detailed history of chief complaints, history of presenting illness and asking certain histories such as birth history, natal history or development history which is not relevant immediately for that child. So when I say focused history, I mean at that point of time and space what is relevant. And subsequently at the next level, once initial stabilization is given, asking for lab tests and other radiological investigations such as X-ray, CT, MRIs, etc. So now we'll come to the initial assessment where we agree to look for consciousness, work of breathing and color. Now in consciousness, what we look for is muscle tone to check that basic muscle tone is maintained and is not acutely hypotonic. Whether there is a look, gaze and interaction of the child, whether the child is having a speech or cry or is consolable. The other apart from this in consciousness, what we can check for is whether the child is responsive or not, in simple terms. So this is something which we gain by experience and by looking. So if we see 100 normal children and then you find one child who is abnormal, you can easily pick up the child who is having an alteration in the speech or alteration in the interaction or tone. Secondly, when you come to the breathing, we look for the work of breathing of the child and to check whether the work of breathing is increased, decreased or absent, and for any abnormal sounds if present. Now abnormal sounds might be present in an airway obstruction. An abnormal sound might even be present physiologically during sleeping, like a snore. But abnormal sound such as stridor is abnormal. Abnormal sound such as expiratory stridor is abnormal, where we should consider a foreign body. Increased work of breathing is suggestive of respiratory distress. Normal work of breathing might give a clue that the child is normal at present, but it can also show that the child might deteriorate based on the other conditions. If the work of breathing is decreased, it is an immediate red flag, which requires immediate assistance through bag and mask ventilation. And absent work of breathing is an even bigger red flag, which might even require mechanical ventilation immediately. So undoubtedly, breathing is the most simple and effective parameter what we need to look for. Subsequently, if we look at the color of the child, a pale child is undoubtedly sick and might signify severe anemia. It might signify significant blood loss. It might signify shock. A cyanose child definitely signifies a circulatory impairment, which requires circulatory corrective measures. Mottled or a bleeding child also signifies that there is an acute blood loss and it requires immediate help. The basic aim of our initial impression is to classify the child into whether the child requires immediate attention or not, and any of these parameters being present signify that the child requires immediate attention. So we'll consider a case where first child is brought with accident from the street, brought by the parents, where a cycle or a bike ran over the child. So they are brought to the casualty, and likewise a child is brought for the sake of vaccination to the same center. Between the two, the first child requires a priority and the second child can wait. The aim of our initial impression is also to ensure that help is given to the one who requires it the most, and help is given as soon as possible. Now with that, we come to the primary assessment. Like I mentioned, it is a hands-on evaluation. What we did in the initial impression is merely by visual. So the initial impression is merely visual. It is merely by inspection, whereas the primary assessment is totally hands-on. The primary assessment is totally hands-on, and in hands-on evaluation we check for the airway, we check for the breathing, we check for the circulation, we check for the disability, and we check for exposure. Now coming to each of these 5 points in detail. In airway, we check for the status being clear, where the airway should be open and unobstructed and the child is able to maintain the airway on his or her own. A maintainable airway can be maintained by simple measures, which can include even postural correction, and not maintainable reads advanced measures such as bag and mask ventilation, or might even require mechanical ventilation in severe cases. Now coming to breathing, in breathing we check for 5 components, namely the respiratory rate, the respiratory effort, chest wall expansion, lung and airway sounds, followed by pulse oximetry. Now in respiratory rate, we check for tachypnea. Tachypnea is an increased respiratory rate, bradypnea is a decreased respiratory rate. Now tachypnea is the first sign of respiratory distress, but bradypnea, that is a decrease in respiratory rate, is much more dangerous than tachypnea. If you see a bradypneic child, it requires bag and mask ventilation immediately and should definitely call for further help. So you definitely need to call for further help in a bradypneic child. A tachypneic child requires a different type of assistance. What is important to note, at any age group, less than 10 or more than 60 respiratory rate is significant. This is definitely in a layman's language. But if you do strictly want to consider age-wise, in newborn anything more than 70, but even more than 60 is considered significant, but in a neonate you can wait even up to 70. Up to 1 year it is 60. Up to 5 years it is 50. And subsequently it goes on to 30, 20, etc. and age-wise cutoff is there. But for a simple layman term, remember that a tachypneic child is the first sign of respiratory distress and bradypnea requires immediate attention. Now coming to respiratory effort, what we need to look for is nasal flaring, that is flaring of the nostrils, presence of retractions. Now retractions can be suprasternal, it can be intercostal retractions, it can be subcostal retractions also. Retractions anywhere is definitely a sign of respiratory failure and increased work of breathing. Presence of seesaw breathing or head bobbing is also a warning sign, along with other symptoms such as upper airway obstruction seen in retraction with stridor, lower airway obstruction seen in retractions with wheeze, or grunting, which is suggestive of a lung tissue injury. Now presence of any of these is sign that there is an increased respiratory effort, And generally what happens is, if the respiratory muscles are not accustomed to that level of work, they do tend to get fatigued easily. To give a simple example, if you have a person who is not accustomed to severe exercise and he is asked to lift a 100 kg stone, if he is even able to do it once or twice, the more he does it, the more he does tend to get fatigued out, and eventually he'll just drop the stone and unable to lift it. In the similar manner, if the respiratory muscles get over fatigued, breathing will cessate, which will result in respiratory arrest. Now, further, if you assess breathing, the chest wall expansion and air movement should be equal. You should look for a symmetrical chest rise and auscultate to ensure that air entry is equal. If air entry is reduced on any one particular side, it means that there is an obstruction. Generally, what we do see, if I draw this as the lungs, if there is a reduced air entry on the right side in the lower zone, it is almost always suggestive of a foreign body. It can also happen in the right upper zone, because as we know, the right bronchi is more straight as compared to the left bronchus. So any foreign body what does tend to fall through will more or less always go in through the right bronchi and will enter the right lung. So the risk of aspiration and foreign body is always more in the right lung. Now coming to the respiratory sounds, stridor, grunting, gurgling, wheeze and crackles. I'm sure all of you as medical students would definitely have heard of these in your clinical postings and have seen these cases. Presence of any of these sounds warrants immediate attention for that child. And pulse oximetry is often considered as the fifth vital. So with pulse oximetry considered as a fifth vital, oxygen saturation to be maintained at 94% in room air is considered as adequate oxygenation, and SpO2, that is saturation less than 92%, requires additional intervention. Previously it was considered as 90, the recent update says it as 92. So if saturation is less than 92%, then definitely additional intervention is required for the child. So on room air, if maintaining less than 92, you initially give oxygen through a low flow device. So the different devices by which we can give it include nasal prongs. So nasal prongs is a low flow device, followed by a face mask. A face mask is also a low flow device. Other than this, in newborns we do have hood. So a hood is where generally a small hole will be kept on one side of a cube and the baby is kept in where the head is there. A hood can function as both a low flow or a high flow device depending on certain circumstances. But a hood can be given in newborn. You also have nasal prongs, face mask. You can also step up to NRM mask. An NRM mask is a non-rebreather mask, which is a high flow device. Apart from this, you can step up to other high flow devices such as CPAP, BiPAP, or even HFNC. So this is just to sensitize you about the different modalities which are available for oxygenating the child. Now further, moving on to respiratory insufficiency, if we categorize it based on severity, tachypnea can be suggested of failure, it can be marked, it can be tachypnic, it can even go to bradypnea. Tachycardia or bradycardia also may be present, and an increased work of breathing may be present along with a decreased work of breathing also. Abnormal airway sounds along with cyanosis or altered sensorium, all of these can be warning signs. Now I have classified all of these on the slide into two ways. One is suggestive of distress. So distress is suggestive by tachypnea, tachycardia, increased work of breathing, abnormal airway sounds. Failure is characterized by marked tachypnea or any bradypnea followed by bradycardia, decreased work of breathing, cyanosis or altered sensorium. So this slide basically classifies for you into what is distress and what is failure. Now moving on to circulation, what we assess for in circulation include heart rate and rhythm, peripheral pulses, capillary refill time, skin color and temperature, followed by blood pressure. In skin perfusion, we check for the cold extremities. Unusually cold extremities is a sign that circulation is impaired. Pallor of severe degree is considerate of circulatory failure along with the presence of cyanosis. Cyanosis generally occurs where the hemoglobin level is brought less than 4 or where the saturation level is markedly less than 80. That's a very crude sense of recollecting, but cyanosis, again we further do subclassify it into central and peripheral. But cyanosis of any sort is suggestive of skin perfusion impairment, which implies circulatory failure. The normal capillary refill time is less than 2 seconds and is generally checked over a bony prominence by pressing, holding for 2 seconds and then releasing. While releasing, we check it in counting 1 Mississippi, 2 Mississippi, or 1 and 2 and 3, like that, to ensure that we do ensure a full 2 seconds is counted, to ensure that we do ensure 2 seconds is counted unless we use a stopwatch if we are checking in a low resource setting. But we should also consider the environmental conditions while interpreting the capillary refill. In a cold environment, a slight delay is considered to be physiologically normal, but in a normal circumstance, CRT must be less than 2 seconds. Now, blood pressure is often something which is widely having awareness among the adult population, but in a pediatric population, a BP is often considered to be a second line investigation, which is highly false. IEP recommendations do state that any child having age 3 years or more should have a BP recorded at least once a year on a routine setting, and most ideal is every hospital setting must have the BP of the child recorded. Now, to call hypotension, in adults we always worry about hypertension and complications, high BP measures to reduce by stress control, dietary control and all. But in a sick child we are more worried about hypotension rather than hypertension. Hypotension is defined as BP less than the 5th centile on the chart. So less than the 5th centile blood pressure is hypotension. In neonates, a BP less than 60 is hypotension. In infants up to 12 months, it is less than 70. If less than 70 plus age into 2, for the child who is age 1 to 10 years, it is considered as hypotension. And in any child more than 10 years of age, less than 90. So for an example, if we consider an 8-year child, the definition of hypotension will be 8 into 2, 16, 16 plus 70, 86. Any blood pressure less than 86 millimeters of mercury systolic is considered as hypotension for a child who is 8 years old. Now further moving on, the reason why we are giving so much of stress upon circulation is it is an indirect indicator of cardiac output, and cardiac output almost always indicates the status of renal perfusion and helps to monitor the response to treatment. For example, if a child is brought in shock and is resuscitated with IV fluids, initially if the capillary refill time was, for example, 4 seconds, after corrective measures, if this capillary refill time has come to normal of 2 seconds, we can imply that our corrective measures have worked and the child is responding to treatment. So it also helps to monitor our response towards treatment. Now, when we talk about circulatory insufficiency, when I say hypotensive shock, like I mentioned, it is blood pressure less than the 5th centile with a change in the mental status. But compensated shock can be considered in conditions where there is tachycardia, cold pale skin, delayed capillary refill time, weak peripheral pulses, low pulse pressure and oliguria. All of these are signs which are suggestive of compensated shock. Now when I come to disability, I talk in terms of central nervous system disability where there is a loss of the cortical function or the brainstem function. Now in cortical function, I am considering the AVPU scale or the Glasgow Coma scale. The Glasgow Coma scale comprises of 3 different components, which is eye movements, response to verbal commands and motor movements. The minimum score what is allotted is 3. The maximum score what can be allotted is 15. A normal child should have a Glasgow Coma scale of 15 by 15. But because of the various subcomponents of it, doing a GCS is sometimes difficult in a detailed setting, which is why we have come to the scale called as AVPU. A stands for alert, V stands for response to verbal command or voice command, P stands for response to pain, and U stands for unresponsive. Now, if we want to correlate the AVPU scale with the Glasgow Coma scale, an alert child will have a GCS of 15 by 15. A child who is responding to verbal stimuli will have a GCS of 13 by 15. A child who is responsive to pain will have 8 by 15, and an unresponsive child will be 6 by 15. What is important to note, generally, as a thumb rule in the ER, any child whose GCS is less than 8 will often require intubation and mechanical ventilation and additional life support. So it is important by just a simple AVPU scale, by checking whether the child is alert, whether the child is playful, by calling out the child's name, by pinching the child to see if there is a response to pain. By these very simple measures, we can easily gauge whether the child is having a disability or not. When I say disability, for brainstem function, because we know vital centers are present in the brainstem, we check for pupillary equality, size and response to light. A normal pupil should be bilaterally equal response, and it should be responsive to a light. The general response is, if assuming this is the pupil, assuming that is the pupil, and if a light is shown, when light is shown there should be a pupillary constriction. When the light is switched off, there should be a pupillary dilation. Now when I say exposure as the final component, we must undress the child as appropriate and avoid exposure to the cold environment. On exposure, we should look for deformities, bruises, bleed, fever or hypothermia, and also look for anything which has potentially contaminated the child. When I say contamination, in cases of poisoning or consumption, we must ensure that the child is completely declothed and is completely given a thorough wash with soap and water. If any bleed stains are present or there is remnants of active bleed, that also must be cleaned off the child, and ensuring that there is minimum exposure for external components through the skin, and ensuring that there is no iatrogenic exposure to the child also. For example, if any open wound is there, it should be dressed up unless otherwise indicated, and unnecessary exposure to the cold environment must be avoided. Now coming back to where we started initially, the primary assessment. In primary assessment, we should check for respiratory insufficiency, for distress or failure, and in circulatory failure, we classify it as either compensated or hypotensive. If any of these components are there, we must label it accordingly and treat accordingly, otherwise we label these as normal. And if we classify based on subtype, respiratory insufficiency can be because of an upper airway obstruction, a lower airway obstruction, a lung parenchymal disease, or a disorder of controlled breathing. Circulatory insufficiency can be because of hypovolemia, distributive shock, cardiogenic shock, or obstructive shock. And respiratory circulatory failure can be because of a cardiac arrest or cardiopulmonary failure. Now, till now, whatever we discussed was a primary assessment. Now, moving on to secondary assessment, where we have a focused history and a focused examination. Now, a focused history is where we ask the current symptoms, any allergies to any medications what the child is on, past history, when was the last meal of the child, and what were the events that led to the problem, and how the child was brought to the current health setup. When I say focused history, this is all that is implied in the current scenario, and it is not the detailed history what we are used to taking of name, informant, address, followed by chief complaints, history of presenting illness, past history, birth history, natal history, immunization history. It is not immediately relevant here. Once the situation is stabilized, we can go for a detailed history and examination at that time. And suitable to the condition, appropriate lab investigations are done and radiological intervention is sought as deemed necessary for immediate treatment and stabilization. And the management priorities in a sick child should be given based on whether the child is stable, whether there is respiratory distress or failure, whether there is circulatory failure in the form of compensated or hypotensive shock and corrected, whether there is cardiopulmonary failure or arrest. If there is a stable cardiopulmonary status of the child, you can do a more detailed workup and provide specific therapy as indicated as per the condition and reassess frequently. And as any case, the priority should be for the child with respiratory failure, followed by respiratory distress. So the airway to be checked, giving 100% oxygenation, assisted ventilation, keeping the child NPO, monitoring saturations and cardiac monitoring. In respiratory distress, ensuring that the child is with the caregiver in a position of comfort, still giving nothing orally, maintaining pulse oximetry and considering a cardiac monitor. If the child is in shock, to ensure that 100% oxygen is maintained and adequate airway and ventilation is maintained, establishing an IV access or an intraosseous access, giving an adequate volume expander, maintaining oxygenation, heart rate, urine output, and considering vasoactive infusions as necessary. The take-home message what I want to highlight is that a rapid cardiopulmonary assessment and appropriate initial treatment gives sustained survival in a critically ill child. And I want to reiterate one more point, that this presentation of almost half an hour cannot replace a complete PALS course. And I have not gone into detail of any of the conditions, be it respiratory failure or respiratory distress. I am trying to highlight towards you, the viewer, on what is necessary to pick up a sick child and to identify the warning signs. What we aim to do is, number one, identify early. And by identifying early, the second aim should be to seek help early. And the aim of seeking help early is 3, to intervene early. So our ultimate motto is to ensure early identification, seeking help early, followed by early intervention. On that note, I thank all of you for paying attention towards this presentation, and I hope that after listening to this presentation, if you do see a sick child, be it your own or be it any child whom you see outside, to ensure that you do whatever you can to ensure maximum help is given. If you are in a healthcare setting, never hesitate to ask for help. It is okay to ask for help in an emergency situation because we need maximum hands on deck. If you are outside the healthcare setting and you do come across a sick child, to ensure that that child is brought to the adequately equipped healthcare center on a priority basis to ensure that the help is given. I also thank the Indian Academy of Pediatrics for ensuring that these slides are available online to ensure that I can take this message out to all of you. Thank you one and all, and I hope you tune into the next video.